so much. Thank you, Claudia, for accommodating the switch. Hopefully we won't hear a screaming baby in the background anytime soon. Okay, so I've sort of tweaked the title a little bit, just because I wanted to bring in some discussion on digital literacy and some of the work we're doing in that area. So feel free to interrupt at any time. I'm just going to try and keep it a little bit informal, although I will go into sort of methods and stuff underpinning some of the analysis we've done. So just a bit of a sort of a background. So the work that I'm presenting today really reflects the inputs and support from a lot of partners. So I'm based at the University of Cape Town, but I also have an appointment at Johns Hopkins. A lot of my colleagues involved in this work were affiliated with Johns Hopkins, but also others at UCT, and then we're working with BBC Media Action and Oxford Policy Management, along with the National Health Systems Resource Council, which is part of the Ministry of Health in India. The work has been funded by the Gates Foundation, both through the India office and through Countdown to 2030. And then we also have other partners in Cadence, which is a phone survey company in India. So just to acknowledge these colleagues who've been instrumental in the work that I'm going to talk about today. So just sort of, I might have learned how to present a little bit better had I had this morning's session earlier, but so bear with me, academics are not known for presenting very well, so hopefully I won't put you to sleep. But I thought it might be interesting to sort of put two questions to you today. And the first is, are mobile phones in and of themselves transformative for women in improving healthcare seeking and practices? The second is, if I give you a phone, are women digitally literate enough to be able to make use of them? So these are sort of maybe topics, questions that we've talked about in different ways through some of the indicator work that other colleagues have been talking about earlier. But I'd like to touch on both of these in different ways in the next kind of 30 minutes or so. So why does this matter? So I wanted to kind of, I don't know if you've seen this sort of well-known way of conceptualizing equality and equity on the far right. But if we can kind of sort of conceptualize these two terms as we all sort of perhaps are familiar with, and we can see with equality sort of three people standing on the same bin, if we viewed mobile phones with that, and we give everybody a mobile phone, equality would then mean obviously the difference in our ability to perhaps make use of them, right? And if we sort of, again, think of this equity as the ability to even have a mobile phone, one's access then has a differential effect on our access to health information, our ability to kind of perhaps make better use of different health services. So, you know, again, this is, if we think about inequities, it's potentially, we see a pro-rich bias in terms of who's reached. If we think about inequalities, this impacts our access to information and services amongst those who do have a phone. And collectively, it really reinforces the notion that mobile phones and digital tools are an enhancement to health services and not necessarily intended to be a replacement. So that's just kind of sort of food for thought as we think about it. And if we go back to our two questions, I want to start with this first one. So I'm going to present some work that we've done doing secondary analysis of DHS surveys. But first taking a step back and sort of saying, why did we do this work? Why is it important? And what we broadly sought to do is link phone ownership among women to key reproductive, maternal, newborn, and child health practices. So why do we want to do that? We want to do that because by 2020, we know that mobile phone ownership will reach near population levels. This is really occurring with a concurrent increase in the proliferation of digital health interventions. And you've all seen that very famous slide from Malawi that shows the circles of overlapping digital health interventions. And that sort of pilotitis phase has really, some would say we've sort of outgrown it, but I still think there's an underlying dearth of evidence on the effectiveness of these interventions. And more important, it's really unclear who we're reaching. So if those of you have looked at the sort of recent WHO digital health guidelines that came out, I think, 2 months ago, Pascal? You see that, you know, some of these sort of issues around who we're reaching were raised, but more as a footnote just because we don't really have the data on it. You might have also seen the annual Bill and Melinda Gates Foundation letter. So when I teach a version of this lecture in a class, I start by playing Melinda Gates on a talk show, being interviewed in the United States, talking about how mobile phones in and of themselves are transformative. And part of the impetus of this work was really to challenge that notion, because I don't necessarily think that they're a magic bullet. And if we're going to sort of simply provide women with phones, I'm not necessarily convinced as an academic it will get us there in terms of health outcomes. So we wanted to sort of, in essence, challenge that assertion in different ways. And it also tells us that we really need to kind of rectify gaps in available data, both on sort of gender, phone ownership, and use. Again, this is some of the themes that you all kindly talked about earlier. There's been sort of inconsistencies in the indicators, as we've seen, and how we conceptualize like kind of what a gender gap is. I thought your presentation did that beautifully by talking about it in different parameters. Often, if you look at some of the GSMA reports, gender gap is conceptualized only in terms of ownership. What does ownership mean? How do we differentiate that from access? So I'm going to talk a little bit about that in different ways. And then for the slides that are coming, we've done a similar analysis for India. The only reason I haven't presented them both is because of time, and two, the indicators used to measure them are different, which I'll talk about. So this study really had a couple of different aims. The first was to really look at the gender gap and explore determinants of women's and household phone ownership. The second was to look at differences in the characteristics of women who own a mobile phone versus those who report using mobile phones for transactional purposes. I'm going to only just sort of touch on that very lightly because the financial transaction data is only available on a subset of countries. And then we wanted to look at associations between women's phone ownership and care-seeking practices. And then we've done what's called the Oaxaca Decomposition Index to sort of break down what factors really underpin that gap. So again, we can sort of talk about this in whatever depth folks feel comfortable doing at 4 o'clock in the afternoon on a what day is today, Wednesday. So the conceptual framework that we were kind of working on, and I think it's sort of interesting I'm missing some of the indicators perhaps that you guys, some of the different data elements you would think of, so it's helpful to maybe think through how we might revise this. But if we look sort of on the far left here, and we look at what factors influence women's ownerships of a phone, we might think of different characteristics women have, starting with their equality, their autonomy, socioeconomic status, where they reside, different sociodemographic characteristics and education, which in turn might affect social norms. According to different surveys, depending, you might have different indicators on this, which include women's ability to negotiate family dynamics, their ability to input on different financial expenditures, and in turn, this could correspond to increased access of phones among women. And then if we look, if I have a phone, what does that in essence mean for coverage of different services? This in turn could lead to access to different health information, improved knowledge and attitudes, improved access to health services, and ultimately improved care-seeking and practices. So this is sort of kind of the idealized linear flow of how you might conceptualize this. And again, as I mentioned, in thinking about kind of how we present the results, I just wanted to first also take a step back and say in terms of methods, we've presented data on phone ownership for 17 countries that have DHS survey data. So this is, as of 2015, we only have data for these 17 countries. 11 have data on financial transactions, which again, I won't go into detail too much on. And then just for those of you that are interested, we've done survey design, weighted estimates. We've done multi-level logistic regression models. And then as I mentioned, this sort of Oaxaca Decomposition Index to decompose any differences in the health outcomes that we see. So I realize this is a little bit of a technical presentation, so you'll have to stop me if you want me to sort of move past into sort of more of a sort of high-level discussion. You can happily to do that. What I'm going to talk to you about are 5 findings in the slides to come. The first is that despite high overall household phone ownership, substantial gaps exist in women's phone ownership, which is not surprising. The gap is inequitable in and of itself, and again, when I refer to the gap, it's between women and household ownership. And this gap has implications for RMNCH care-seeking and practices. That gap is really driven by higher education and residence. And then ultimately, this sort of broader plea that we have limited data and our metrics themselves need to be revised, both in terms of ownership, access, and digital literacy. And in the absence of our ability to sort of improve these, we're still going to be sort of largely sort of ruminating around the results we're seeing and why we're seeing them without an ability to sort of explain why. So the first thing, this first comment on the first point of there is a gender gap in phone ownership. So if we sort of look, just to orient you to this slide, if we look sort of at our y-axis here, we see the percentage of female ownership, and our x-axis is the percent of household ownership. And again, this is the 50% line in both. And the size of the circle denotes the population size, and the colors correspond to different WHO regions, okay? So just roughly what we see is that household ownership for all countries is above 50%, which is great. But women's ownership is much lower than that, in particular in 4 countries. So you said Ethiopia is around 27%, Malawi 33%, Pakistan at 39%, and Uganda at 46%. So I don't know how this offhand corresponds with your data, but just from the DHS, this is what we're seeing. And if we look at sort of what underpins this gap, we see again that it's inequitable, that phone ownership is really highest among urban residents, individuals in the higher socioeconomic strata, those with secondary school education, and those with less than or equal to 2 children. So again, you can see these parameters here in the column this way. I've highlighted that so we can see that. Lastly, we see that as well, younger age groups are less likely to own a phone, particularly women, which perhaps goes against, sort of what is counterintuitive, I guess, unless you think about the resources to obtain them. If just taking a step back, if we wanted to look across socioeconomic strata, just to orient you to this, sorry that the font is a little bit small, but what we see are different countries here, starting with Pakistan, Senegal. You'll see in a second why they're organized in the way that they are. But in essence, we see by the colors denoted here that starting with red is the poorest, and the far right is the richest. In essence, we see these different dots then looking at the gender gap in phone ownership by strata. So if we look here, this is the percent of household phone ownership. And if we next consider women's ownership here, and again, this is women's ownership by SES, household ownership by SES, and then if we take the difference between the two, we get the gap, right? And what we see ultimately is that the gender gap is greatest in Pakistan, and these have thus been ordered by the magnitude of the gap. And we see, in essence, that across different countries, you see sort of substantial disparities across socioeconomic strata. So taking Ethiopia as one example, we see sort of 81% phone ownership at a household level compared to 9% in women, constituting a gap of about 71% amongst the poorest. Amongst the least poor or the richest, that gender gap is substantially less at 29%. So you do see these differences even within countries. Here's Pakistan, you can see it at the top. And here's Malawi and Ethiopia, which I just referenced. So in a number of countries, we also see the sort of the opposite of that, which is that the gender gap occurs amongst the richest. There's a smaller gender gap amongst the poorest and the greatest and the richest. So you see in Malawi, there's a gender gap of about 3% for the poorest and 27% for the least poor. In Ethiopia, again, 17% for the poorest and 24% for the least poor. So this trend may be associated with lower levels of household and women's ownership, and we see, in essence, greater inequality in ownership across the strata. So if we look by residence, so this again, red is rural, the sort of light blue is urban, and it's again the same sort of idea where you have the gender gap is the one here on the far left, the household gap in residence is the middle, and then the women's is on the far right. We see that the gender gap by residence is really, again, greatest in Tajikistan, Senegal, and Pakistan. So these kind of two, sort of Senegal and Pakistan, you'll see are the sort of usual suspects for both the greatest gap in SES and by residence. And again, this trend is associated with lower levels of and gender inequality in women's phone ownership. Ethiopia, again, featured here. We see that if we sort of take the gap, the household gap, so we're taking it this way now, we take urban versus rural, that's about a 41% gap. If we look at women's, it's 71% versus 15% in rural areas. It's about a 56% gap between urban and rural. And that same sort of margin for women is denoted here, so that's about 56% here. For Uganda, it's 34%, and so on. For Malawi at the bottom, it's about 38%. So if we were to sort of conceptualize this in a different way, and we were to say, okay, why does phone ownership matter for health outcomes? One way to do that is to do something called a heat map. So I realize this is overwhelming and it looks like a quilt, but I'll walk you through it very quickly. So this sort of heat map depicts the relative gap in the prevalence of health indicators among women with and without phone ownership by country across different health indicators. So the countries are located here, and the different health conditions for which we have data are located on the y-axis. So we see basically in the green colored cells, what they denote is higher adoption of a particular health practice among women that don't own a phone as compared to those that do. So we'll break that down in the next couple slides, but what we see in the orange cells are higher relative gaps amongst phone owners versus non-phone owners. And the black cells denote no difference. And the light gray is we don't have available data. Okay? So just to sort of take an interpretation of here, so what we see again, if the relative gap in prevalence for infant feeding, specifically initial, continued, and exclusive breastfeeding, is really higher among women without a phone. So that means we have a pro-poor bias for these particular indicators. By comparison, if we look, I'll show other indicators in a second, but we see the relative gap in the prevalence of care-seeking. The relative gap in the prevalence of care-seeking is higher for women with a phone versus those without. For early ANC, antenatal care 4+, skilled birth attendants, and for both maternal and child postnatal care. So it's sort of, you have both sort of a pro-rich bias and a pro-poor bias there, depending upon the indicators which you're interested in. Sorry, please.
So just a very quick question, is that adjusted for anything?
Yeah, so these are all, it's part of a multi-level model. Sorry, the next one's part of a multi-level model. This is not. This is just taking the prevalence among non-phone owners less the prevalence among phone owners divided by the prevalence among non-phone owners. Does that make sense?
I think so.
Yeah.
But
sorry.
so this, I mean, you could be capturing the fact that non-phone owners are likely to be lower socioeconomic status.
So we'll get there with so I'm going to present a multi-level model next that adjusts for everything, and then we'll talk about the Oaxaca decomposition index, which unpacks the gap and what factors are associated with it. You were going to ask something.
Again, just a quick clarification.
Yeah.
Health services, digital based, or are you looking at just the general use of?
Yeah, thank you. That's an important point. So these are data from the demographic health survey. So it just asks, for example, treatment for diarrhea in the last 2 weeks. Did you take ORS and zinc? For vitamin A, did you have vitamin A supplementation in the last 6 months? I'm trying to think what some of the other indicators are. Immunization for DTP3. So forth. So it's in essence the health indicators agnostic to digital available in the DHS. Yeah. Okay, sorry. All right. Okay, so if we really wanted to kind of look at again the implications of phone ownership on different health outcomes, adjusted for a variety of those characteristics you saw in the conceptual framework. We see that phone owners have significantly higher utilization for a handful of RMNCH outcomes. So these are highlighted in gray. The ones that are not statistically significant fall at the bottom, but I just wanted to show you what we considered. So this is part of a much more complex model. We have bigger tables if you want to see. I've just distilled it for the presentation. But basically what you see, again here is that under maternal health indicators, phone owners really have higher utilization for tetanus toxoid immunizations during pregnancy, the ANC indicators, demand satisfaction for family planning, skilled birth attendants, and postnatal care. That maps quite nicely with the heat map that you saw, which is the relative gap in prevalence, and for child health as well. And similarly, you saw on the heat map, we see a sort of pro-poor bias. It's not, again, this goes in the direction that does too, indicating that we're not seeing an effect among phone owners for those infant feeding practices. If we look across socioeconomic strata, again, we see a pro-poor bias, meaning the poorest are better able to make use of a phone for demand satisfaction for contraceptive across socioeconomic strata, for tetanus, for vitamin A, and for DTP3 immunizations in children under 5. So I realize this is quite data heavy, so feel free to, again, stop me. We also have a paper if you want to read about this at night and go through this. You're welcome to. Yeah, go ahead.
Question, in terms of controls, you only have the social economic status?
No, so I just presented it by that. So I think I might have shared with you the larger paper. So I can go back to the conceptual framework, but it, in essence, adjusts for all sociodemographic characteristics for which we have data in the DHS.
But also only
Education, no, so education, socioeconomic status. And we've just pulled out, just as an example, to show differences by resident, socioeconomic status, et cetera. But it's a multi-level model that adjusts for all those other covariates. Yeah, okay.
Sorry, does it adjust for any health system kind of supply side factors?
No, so that's a problem because we don't have data. So let me just go back to that conceptual framework just to give you a better sense. Okay, so the light, white boxes are things for which we have data with the exception of gender equality and women's autonomy. I want to mention in the final DHS analysis, we were not able to adjust for social norms because it splits the data set up so much that you don't get meaningful results. For the India analysis we could adjust for social norms. So anyway, I just wanted to flag that. But otherwise we were able to, in essence, it becomes an analysis amongst women's characteristics and the different outcomes down here, right? These are nice to have, so we'd love to have them if it didn't split our data set up so much in the context of this larger DHS analysis.
So in the multi-level, you have only individual level. You're using multi-level because it's cluster, but you don't have any aggregate level variable.
So there is, it depends what you mean. Like countries are pretty aggregate, so it's adjusted for countries, right?
Okay.
Because it's 17 countries that were included. But by comparison, for example, so no, we did, because we didn't do another analysis that broke it up by, if you look at the numbers of countries included by different WHO regions, it's quite small. Yeah. So it didn't make sense to sort of further subdivide the 17 into different WHO regions. Okay, all right, let me keep moving. This is the much drier of the two. I think I want to get a little bit into, hopefully we can talk about digital literacy if we get through this. Okay, so just again, along the same lines of that sort of a adjusted model, we've looked at this already. Oh, sorry, hold on. Okay, so this is where we were, I believe. So again, as I mentioned, we're able to see sort of that the poorest are able to make better use of the phone just for these main 4 indicators. By comparison, we see this pro-rich bias where the richest are able to better make use of the phone for ANC4+, skilled birth attendants, and newborn postnatal care. And we've presented kind of the adjusted odds ratios here for those. And you might sort of then think about kind of why are we seeing this? So we really, perhaps, we don't, again, we just sort of have to sort of make assumptions, but we think we might be seeing the sort of pro-poor bias for tetanus, modern contraception, vitamin A, and DTP3 for 3 main reasons. One, they're done in campaigns or through community-based outreach initiatives. They all require some kind of structural inputs, and in most cases, they're usually available at free of cost to users through the public sector, which could, in essence, enable us to make better use of the phone. If you have it, you can just go to the facilities and get it, or a healthcare provider comes to you. In terms of the pro-rich bias, why do we see a bump for ANC4+, skilled birth attendants and newborn care? Could be the fact that women tend to live in good neighborhoods, and that's linked then with the facilities. We note that antenatal care 4+ requires earlier identification of pregnancy to kind of avoid the sort of timeout of not being able to get all 4 of the recommended antenatal care sessions. This could mean that you've gone to the clinic multiple times, which could be something that's quite challenging for the poorest. Skilled birth attendants, again, it's usually higher amongst those in the higher socioeconomic strata, so that's perhaps not surprising. For newborn and postnatal care, again, that's usually tied to facility deliveries. So it's usually occurring prior to discharge after delivery. So that may explain why we see that. So I'm going to jump from making this link between phone ownership and health outcomes to then sort of asking this question of what drives that gap. And so we've done something called the Oaxaca Decomposition Index. I'll explain what that is in the next slide. But in essence, I'm going to make 2 points from this section. So if you forget everything else, this is the take home. And that's that higher education and residence are really key drivers of the gap between phone owners and different health outcomes. So for skilled birth attendants and antenatal care 4+, we see that phone ownership is associated with increased utilization, but that gap in utilization between women that own a phone and women that don't is primarily driven by wealth and education, which is not surprising, perhaps. And we call that sort of underlying attributes. For immunizations, we see a different story, and we see that the difference in utilization of services between women that own a phone and those that don't own a phone is more likely to be driven by women's ownership of the phone than underlying attributes. So, take home, if we sort of were to say, okay, if I dump mobile phones across women globally and we were to make a broad generalization, is that going to do any good for health? And roughly, we think it may do something for immunizations, but other factors likely influence, the other, care seeking for antenatal care, skilled birth attendants, and other health indicators of interest. So how did we arrive at these 2 points? So we've done this sort of, again, what I said was a decomposition index. It's quite technical, so I can already see, I'll be quick, perhaps, but if you want to get into this, I'm around. Please feel free. We'd love to talk about this in depth. But in essence, what this is it breaks down the gap in health outcomes between women with a phone and without a phone in 2 components. So it's something called endowments and something called coefficients. And then the combination of the 2 is an interaction term. So endowments really, in this case, it's women that do not own a phone are worse off than women who own a phone in terms of sociodemographic characteristics, so their underlying attributes, right? Coefficients, it's women with certain demographic characteristics did not derive the same benefits did not derive the same benefits of mobile phone ownership as perhaps other women. So for example, the richest women the poorest women don't necessarily derive the same benefits as the richest women if you give them a phone, right? It's a little bit like saying, I have a phone because I'm wealthy, as opposed to, and as a result of having a phone and being wealthy, then I get a bump in skilled birth attendance or something else, yeah. Okay, so if we were, again, to pictorially look at this, and this, again, going back to the supporting arguments, you'll see the sort of output similar to that on the right, which is basically, again, looking at endowments versus coefficients, and bars going to the left suggest that it decreases the gap. Bars going to the right suggest that it increases the gap between phone owners and non-phone owners, right? So if we look here, we see different characteristics. So we've got the poorest is the reference case, the poorer, the middle, the richer, the richest. And then we look at education, primary, secondary, higher education. We look at residence, healthcare, number of children, and so forth, a number of different age groups here, marital status. And in essence, if we try and look at which of these factors help decrease the gap versus increase the gap, we see that wealth and education reduce the gap in prevalence of DTP3 amongst women with and without phone access. By comparison, if we look across higher socioeconomic strata, we see that the more educated are able to benefit more from phone ownership. Similarly, married rural women over 19 years of age also benefit. So I realize this is quite technical. If you're more interested, I'm happy we basically generated similar figures to this for all of the major health indicators if you'd like to see it. I've just taken out DTP3 and antenatal care 4+ here just to kind of give you a sort of a taste of the data. But similarly for antenatal care as an example, you see again education and rural residents reduce the gap between phone owners and non-phone owners and utilization of ANC 4+. Across socioeconomic strata, we see that at the higher socioeconomic strata, those that are more educated are in essence unable to benefit more from phone ownership for antenatal care, whereas married women benefit. So we're trying to, in essence, break down the relative contribution of these different characteristics to that gap in utilization between phone owners and non-phone owners. I won't get into skilled birth attendants, but it mirrors something similar. So the last slide on our fifth 5 points was really sort of just this plea for needing to enhance metrics for measuring phone access, ownership, and digital literacy. So as I mentioned, if we looked at how these data are generated and what the indicators are that underpin them, for the demographic and health survey, we have just a simple question that says, do you own a mobile phone? That's asked both at a household level and in the women's module. And so the data that I've presented come from that, those two modules. In India, we have something called the National Family Health Survey, which is a pretty incredible repository of data as well. That's been done all the way down to, I believe, the block level in India. So it's a massive database. We were able to do a lot more with that particular database. But we have sort of slightly more arguably problematic indicators in that. And the indicators there, for example, at a household level, it says, does your family have a mobile phone? The women's survey, do you have any mobile phone that you yourself use? Which has limitations. Obviously, it combines issues around access. So do you have any mobile phone with digital literacy that you yourself use? So, it's quite limited. There's another question in the National Family Health Survey that says, are you able to read an SMS text message? And of course, this is relying on reported measurement. So in some of the work you'll see in other slides, we've also tried to look at sort of observed behaviors around digital literacy, and I'll talk about that in a minute. And last question that they do ask, So the last point on this is that it's also asked as part of the domestic violence module, so it's a much smaller subset of the larger survey itself. Okay, so for this analysis, we have a couple of key take-homes that I'll just sort of reinforce beyond those first 5 points. And the first is that high overall household ownership exists, but there are wide variations in the women's ownership, corresponding to a fairly sizable gender gap by region. I didn't present India here, but we see about a 50% gender gap in India overall across the country, with variations across states. Otherwise, by WHO region, we've sort of just summarized the gap here. Highest in Eastern Mediterranean. Again, very few countries have available data, so just sort of be wary of that when you see us sort of summarize the gap by region. We see again that the likelihood of phone ownership is significantly higher among women in the highest socioeconomic strata, with greater than secondary school education, with one child, that are over 19 years of age, and that are unmarried. So clearly there's a differential in the characteristics of women that own a phone and those that don't. That's important. So does phone ownership matter for health? As I said, yes, but phone ownerships have significantly higher, phone owners have significantly higher utilization of different RMNCH outcomes, but that effect is differential. So again, you see this pro-poor bias in utilization for DTP3, vitamin A, tetanus, contraception, and a pro-rich bias for a number of the indicators we've discussed. The gaps in rates of most indicators between phone owners and non-phone owners are reduced by higher levels of education, and we see that married, older, rural residents tend to benefit. And as I said, if we sort of look overall, what we see is that probably equipping women with a mobile phone may improve immunization coverage itself, but for skilled birth attendants, antenatal care for, it's other factors such as your socioeconomic status, tend to drive that gap more. So I'm going to shift us to our second question. I'm going at a little bit of a clip, I realize, so do feel free to pause, have me stop at any point.
Sorry,
yeah.
Before you go there, do you mind just going back to the main points, just for the interpretation there?
Yeah.
So for the pro-poor bias, then my understanding is the phone ownership is capturing socioeconomic status and education, actually, that the effect of those things together. Lumping it. And then for the immunization, it's not, there's something else going on. Why do you think that the phones are having that effect on immunization?
Yeah, so it's not, again, this is, I hate to parrot what you were saying, but it's very frustrating because we're very limited in what data we have, right? So even, it's also kind of, you talk about methods. What's interesting is even in the discussion of how to approach this analysis, typically for what we do for DHS surveys is stop at the multi-level model. Like, we don't go forward with a decomposition index. And the decision to do that here is because I wanted us to understand what drives that gap. So if we had stopped at the interpretation of the multi-level model, it would have been cleaner. You know, I could have just said, oh, you see significant uptick in those, you know, indicators on the far right but really by then taking it forward and looking at the decomposition index, trying to explain why there's that gap, it's the other factors, you know, play more. And so for immunizations, the only thing that I can think of to sort of explain is sorry, this slide here, sorry. Where is it? Yeah, it's this one here. So why these findings? And I feel free to disagree with me completely, but
I guess my question is, how is the mobile phone causally?
We can't make that.
I mean, I know we can't.
Yeah.
But what's the hypothesis then? Is it that they're, I don't know, the fact that they have a phone, they are able to get transport or?
So for immunizations themselves are going to be done through campaigns, right?
Yeah.
So it's going to be a little bit like you see the pro-poor bias for tetanus, modern contraceptive, like, you know, vitamin A, etc. People come to your household, and it could be just, again, that you're made aware of the campaign through an SMS blast, or, you know, you having access to the phone means you have access to health information, which in turn means that someone showing up on your doorstep to immunize you could mean that all those other barriers which limit my ability to make use of the health information received over my phone or my ability to communicate with a health worker, etc., are overcome, because you're, in essence, almost providing point of care services. With antenatal care and skilled birth attendants, I should say antenatal care 4+ and skilled birth attendants, again, I think they're tied to other factors, and it's not a surprise to me that you wouldn't see a bump in skilled birth attendants because of the phone. You know, again, it's tied to, you know, family dynamics, it's tied to, you know, cost, financial issues.
Yeah.
So, you know, perhaps in that sense, what we're seeing isn't revolutionary per se, you know, and we could see, I would like to, if we could fix the metrics, we might see a change over time that would allow us to sort of perhaps, you know, better explain why we're seeing what we're seeing with more comprehensive data longitudinally. Cool. Can I show you? Okay, all right, I'm gonna switch topics to something that's more fun. Okay, not this is fun, but you know what I mean, okay. All right, so this next question, I think, you know, we've sort of been dealing a while with sort of issues on what are the implications of phone ownership and access, but as we've kind of seen this proliferation of programs that are equipping particularly health workers with tablets and digital tools, it's led us to this sort of line of work of thinking, okay, if I give you a device, are you able to use it? And what we've seen in our work in India, which is what I'll present on a little bit, is that you know, there are large-scale initiatives which I don't get into today, but which will equip all 800,000 ASHA workers by the end of next year with some kind of tablet or mobile device that'll similarly equip Anganwadis. So you have large-scale efforts to, in essence, equip health workers with mobile tools and digital tools. And a more limited effort has been made into sort of validating the content of what goes on that tool, and even more limited effort into ensuring that health workers can even use the tool. And so we did this work as part of the larger evaluation of an initiative called Kilkari in India. So Kilkari is the largest maternal mobile messaging service currently being implemented globally. So I'm the PI of an evaluation of that program, and it cuts across 13 states. And we did baseline survey activities and used that as an opportunity to ask a lot of other research questions, and one of which was trying to quantify digital literacy among pregnant women and digital literacy among cadres of frontline health workers called ASHAs, which are accredited social health activists. So I'll present a little bit, but why this work? So again, we think that phone access and digital literacy are really integrally linked to program reach and exposure in the context of direct-to-consumer messaging programs, but also really linked to the quality of data and the performance of the health system that we're going to get. If I can't use the device, I'm going to either input rubbish data, or I'm, potentially going to it's going to potentially have adverse consequences on the service delivery in different ways. So in our case in Madhya Pradesh, the work really was trying to help us understand the profile of Kilkari users, so subscribers to this mobile health information service, and potential impediments to their uptake of the messaging. We're also looking at it more broadly to help us have this discussion of how do you measure phone access, how do you measure digital literacy, which has more broader applications for the design of digital health programs and population targeting going forward. So just to say that we've since progressed into doing something called Bayesian network analysis, which is a form of artificial intelligence to try and segment populations based on these data and try and then devise strategies to target them more effectively, as opposed to coming up with a homogeneous intervention that I just give to everyone. Can we instead have more targeted approaches and use data to do that? And this links to this last point, which is, do we need these differential approaches to, in essence, come up with tailored strategies to address different health problems to different populations, whether it's female health workers or pregnant women. So it was interesting to see kind of how you had sort of defined by different indicators access and use. So we've defined it in very more basic terms. If you could have a step back even from your basic terms, and we've tried to do that here a little bit. And so we've defined access in terms of the number of phones one has, in terms of ownership, in terms of sharing, in terms of time. And again, I say this is very specific to the India context. So just keep that in the back of your mind. If we think about use, we think about the characteristics of the phone, the type, so is it a smartphone, is it a dumb phone, feature phone, etc. What features are on the phone, and what's the quality. So we found that it's pretty vital that when you're doing assessments that you actually observe the behavior in a person, and then as part of that, you have to see if they can turn the phone on. If the phone is in a condition, doesn't have a cracked screen, they can operate the phone effectively, in essence, to do what you're asking them to do. There's also issues around the network, issues around the environment, and as I mentioned, digital literacy. I'll get into that in the slides to come, and then user engagement. So for digital literacy, just to mention, so we've taken a very, very basic definition of it, probably the most rudimentary definition. I was interested to see that you're doing a lot with mobile internet, etc. We're just not there in rural India. Only 10% of our sample has access to a smartphone that has mobile internet on it, and let alone data, having money for data, etc. So this is very much like a on the ground step back at what we can reasonably get. So if I take that same sort of framework you saw a version of earlier, and we tweak it to sort of have us help conceptualize what factors not only influence women's access to a phone, but what factors influence their engagement. So we have the same sort of usual suspects here of women's characteristics, social norms. It leads to improved phone access, which again we've defined in terms of numbers of phone ownership, sharing, hours of day in possession, time of day in possession. And all of these sort of matter programmatically. If I'm going to send you health information messages, I have to make sure that you're there for the potential exposure window. And then how do phone characteristics, the network characteristics, and environmental factors then play upon your ability, in essence, to optimize the health behaviors and take up the health behaviors that we're trying to encourage change in. For digital literacy, as I mentioned, we've tried to sort of look at it according to parameters of whether or not you can understand basic audio content. So if I play a message to you, and it's asking you to press 2 if it's a doctor, press 1 if it's a midwife, can you perform that basic task? If I ask you to dial a phone number, can you do that? If I ask you to open an SMS, can you do that? If I ask you to open and read an SMS, can you do that? If I ask you to where you store your contacts, is it on a phone or are you writing them on a separate piece of paper? So again, we've taken the sort of the lowest bar of possible digital literacy in this population. And then of course for phone use, it's the usual suspects of are you using it, what are you using it daily for, what are the reasons for the use, and again, the availability of different apps and features on that phone. So I'm going to pull out, we don't have time to get into all of this, so I'm just going to, we have similar sort of multi-level models that get into factors that influence access and use. Just for time's sake, I won't get too much into that. But just to sort of give you a context of where this data came from, so Madhya Pradesh is the size of South Africa. So, and when we're talking about India, often we were just having a conversation over the break, just to sort of emphasize that the scale of states is quite massive. So it's got a population of just about 54 million, so it's pretty big. So we're in 4 districts. We started with a household listing that touched 750,000 households. Out of that, we were able to get pregnant women that met different criteria of about 28,000. We were looking for a population of women that were 3 to 7 months pregnant, which is about half of these women. So this is our sample. So keep that in mind when I present data, because it's always about who your sample is. So about 52% of this population of pregnant women had access to a phone. And if I further took any access umbrella and I cut it down to saying, do you have access at times other than in the evenings only? Because we needed you to be there at some point when you could potentially get messages. We see that about 25% drop out there. So 74% have access other than the evenings only. So these women then constitute this 5,000 population. We interviewed them, and then amongst those, about 76% own a phone, 24% don't own that phone and share it. It's the husband's or someone else's, right? But even among those that own a phone, it's worth noting that a large proportion of those, about a third in our sample, also share that phone. So again, I think this issue of sharing is pretty important, even amongst women that reportedly own a phone. Phone access among women. So again, it's, as I said, this is a restricted sample. We see that there's a median of about 2 phones per household. When we ask who do you share it with, in this context, it's largely the husband, which is not surprising, or other male family members. In terms of the hours per day within reach, again, half the population has it within reach about 21 to 24 hours, which is good. If we look at what factors influence ownership, again, it's the usual suspects of geographic location, being the key driver. We also do see that the odds of phone ownership is significantly higher among women that are older, that are 25 years or more, that are not within the in India, the lower ethnic groups of scheduled castes and tribe, that are in the higher socioeconomic strata and that have higher education. Again, not surprising, just to underscore that these characteristics are pretty important in thinking about who we reach. I've skipped over a lot of issues around use, just because I know I'm short on time. I just wanted to talk about digital literacy for a minute, but just to say we have a lot of slides on phone use if you're interested in that. So I'm going to skip to it, and I realize in the back room you can't see it, so let me just walk you through this. So again, if we take, this is looking at digital literacy among pregnant women, and again, we've defined digital literacy according to your ability to comprehend a message. So that's, can you navigate IVR prompts? So if I play you a message and say, can you hit 2 for the doctor, 1 for the nurse, can you do that? Where you store your contacts, can you open and read an SMS, and can you give me a missed call? What you see is, again, amongst that larger sample of pregnant women, which I walked you through, remember we had the 5,000 that could access the phone times other than just the evenings. We see that 94% of those were interviewed for a variety of reasons. We could find them. And about 85% of those were able to sort of navigate this IVR prompt, which is pretty good, right? But again, bear in mind, this is the lowest bar. So 15% of women that have access to a phone, that own a phone or share a phone, can navigate that prompt. And that's not really asking them to do much, it's just listen to a message. If we look at the other characteristics that we're looking at, and again, the drop-offs here on the right are really looking at, can I observe your phone? And if I observe your phone, does it function, right? And we basically, what we see is that you see much stronger drop-offs for each of these other parameters here, culminating with about 34% of women able to perform all of these tasks, being quote-unquote digitally illiterate. So if we look here in terms of opening and reading an SMS, only 59% can do it. If we're in terms of, only 38% can do it. 59% can open the SMS, but only 39% can open and read it. In terms of giving a missed call, again, it's higher, it's about 84%, so people are able to do that task. But in essence, what we see is when we drill down to what people are capable of doing on their phone in rural areas of India, we see that we're quite limited, which has strong implications for the types of interventions using digital that we want to design to target these women, and or the strategies we need to consider undertaking to sort of help bolster that. For health workers, you might expect a slightly higher bump in terms of services and what they're able to do in terms of digital literacy. So this is again a cadre of frontline health workers called ASHAs. So we have a lot of other data on them, which I'm happy to present, but in essence we see that about 88% of them can comprehend the IVR message. So right away 12% of this cadre of health worker cannot even use the phone to navigate basic prompts. Which is a problem if I'm expecting you to input growth monitoring data, right? Like that's a much higher bar of something I would expect you to do. Similarly, if we look at some of the other indicators where your contacts are stored, out of the total sample, about 65% can do that. Out of the total sample, about 54% can open an SMS. About 87% of those can read the SMS. So cumulatively, it's about 46% can open and read an SMS, which is a problem if I'm expecting what I consider to be a literate population, for the most part, to be able to perform tasks around data capture. We have a long way to go if we want to get good data. In terms of missed call, it's again, 77% of the total sample. I think this sort of underscores larger issues around the types of strategies we need to design to help bolster the success of digital innovations as we think about inputting them into complex health systems. We could get into, if you're interested, what factors drive digital literacy. We've done that. It's again similar, the usual suspects. It's geographic location, ownership of a phone, your age, your position in terms of ethnicity, your higher socioeconomic status, your status, and your higher education and your position in a higher socioeconomic strata. So I won't get into the endowments gap, but we've, in essence, also done a similar thing here, where we've decomposed that 26% gap in digital literacy between phone ownership, and you see kind of the reasons that explain that. So just sort of to close out on this last slide, what are the implications of kind of some of this work to date? I think for programs, I think it's vital that we really think about who we're reaching. You can see from the different cutoffs at different levels, in terms of trying to optimize exposure to some of these digital health interventions, that at the end of the day, there's really almost a pro-rich bias in terms of the populations that have access to digital, and in turn can utilize digital in the way that we're intending for it to be utilized. This, for me, highlights the need to consider differential programmatic approaches to reaching specific subpopulations, particularly around some of this sort of segmentation type analyses that we're just now kind of trying to do. Again, we need to account for variations in digital literacy, not just amongst the population, but amongst health workers as well. And then we really need to help devise strategies for improving digital literacy in different ways. So just even the ways in which I've defined digital literacy are very different than some of the global standards, which then sort of says to me again, we need to sort of reconcile what we're doing at a global level and what's maybe realistic at a country ground level, given where we are. For evaluators, I think from a research side, we really need to enhance our definitions and approaches to measurement. And can we really broaden what we're measuring and make sure that we advocate to put them in special surveys like demographic health surveys, some of the surveys in India that are done routinely, so that we do have better data. And again, I do think there is, despite some of the prior discussions on phone use, which draw largely upon the call data records, in low resource settings, so far we haven't had a lot of success, at least we haven't, in getting those data from mobile network operators. So that could mean that we need to sort of liaise better with mobile network operators directly, or work through conduits like the GSMA to figure out how we can better sort of work with industry to sort of to analyze data for health needs in more effective ways. So that's it. Thank you for your time, and I'm happy to take questions going forward. I think I've lulled you all to sleep. So. Great.
Any questions? Anyone from the
I think you're up, Claudia. off the hook.
I have a very
Please, go ahead.
basic practical question. I'm wondering how long the interview process took, because I actually like the indicators you were using to get digital literacy, and they're more real. I mean, they relate more to the way people use technology, to the things that they may need to do to access the types of services that are now being increasingly offered by SMS. But it sounds like quite a
Yeah, so we're doing another, my team's just starting, we just finished cognitive testing for some of the tools, which is also another thing. So two sort of pet peeves. One, I think often when we develop surveys, these special surveys, there's such a huge gulf between the researchers and the language we use to devise those indicators and what a woman on the ground understands. And with the data collectors in between, they'll do anything to kind of move a very lengthy survey quickly. So we've gone through a whole approach of cognitive testing all of our tools, which I don't think is done enough in public health. And particularly, we tend to rely often on these standardized survey tools where we're like, oh no, DHS has been using that indicator, they must have done testing. We found that a lot of these indicators don't work in rural areas. Like, they'll give you a response, but they don't really understand it in the way that I intend for you to understand it. So I'm getting data back, but me sitting at my computer in Cape Town, I can't differentiate good data from bad data. So for example, like in the issue of Likert scales, those are a no-go in rural India. Like you'll get data, but it's bad data. So to your point though, on digital literacy, what's I'm seeing as well that this coming year, the indicators we're using for men are totally different because their digital literacy is from the early testing we've done much higher, so we can then ask them a greater breadth of questions. So we're just doing a men's survey now, and it will ask questions about like internet use and other things. Where for women, when we did this a year ago, it didn't make sense to ask just because the rates of utilization were so low. So yeah, I think we're scraping the surface, but it's different.
And are they all tested in the same way, like how you test whether they can respond to?
So what we do, thanks for asking. That's great. So what we do is we start with it's an entire module on digital literacy. I can share it with you, but it starts with can I see your phone? And we pose a series of questions to people who agree to allow us to see them use their phone in front of us. Like, I think there are a lot of ethical issues around me looking at your phone, so I don't want to navigate your phone. I don't know what I'll see, and then, not for you personally, I just mean in general. I'm not judging what's on your phone, but, So no, so what we've done is, if you can produce your phone, then I ask you, I'll play you a message, and you tell me what you heard, and that's the IVR navigational prompts. If you can do that correctly, then you move on to the next, then it's, can you dial this number? And we give them a number. It's usually like a 1-800 mobile network, operator standard number. If you can do that, great. And so forth. We go through each of it in a stepwise fashion where we're actually having you perform the particular task at hand. So that's, again, it's much more time consuming. The DHS just says, oh, can you send an SMS? It's just asking you to say whether you can. So it's going to be a bias towards over-reporting of, particularly among men, as we've learned, to say that they can do that. So,
Okay, can I just say that you're not off the hook?
Oh.
but I think the questions will feed into next steps.
Cool. I'm happy to